Good evening. So welcome to the Trauma Symposiums. So in this symposiums, three speakers will present three presentations. After these presentations, there will be a Q&A sessions. Because of the time limitations, we will start the symposiums. So may I call upon the first speaker, Professor Winchaw, for his presentations. Professor Winchaw originally he is a surgeon. And in 2013, because of the country needs, he changed his career as an emergency physician, and now he's working as the clinical professor, emergency department of the Yangon General Hospital.
Symposium. Good evening, good evening, good afternoon, good afternoon, good afternoon, Chairman, distinguished guests, professors, and ladies and gentlemen. Today, I am very pleased to have a chance of my presentation in this surgical conference. My topic presentation is current trend in management of the trauma patient in Yangon General Hospital Emergency Department. Abstract is already mentioned in the booklet, and I will skip this page. And trauma remains a leading cause of morbidity and mortality globally, and necessitating the continuous advancement in resuscitation strategies to enhance the trauma patient's outcome. Invention and availability of the modern medical devices, such as the portable ultrasound, portable X-ray, EVG machines, CT scan, and 3D CT scan also included, and MRI scan have revolutionized the clinical concepts and patient management. And also, skill lab and simulation training courses are very much popular nowadays, and they also play a vital role in the training program for doctors and nurses. And moreover, recent development of the emergency departments in Yangon, Nebiro, Mandalay General Hospitals dramatically changed the trauma patients' care nowadays. In the context of resuscitation, trauma resuscitation is a crucial piece in the continuum of the trauma care and encompassing the immediate response to injuries, stabilization of the patient, and the initiation of the intervention aimed at preventing the further harm and optimizing the patient outcomes. And rapid and effective resuscitation is pivotal in the management of the trauma injuries, particularly in case of hemorrhagic shock and multiple system trauma. In reality, there must be good communications and multidisciplinary collaboration emerges as a cornerstone in effective trauma resuscitation. Seamless coordination between the emergency physicians, trauma surgeons, anesthesiologists, and critical care specialists proves the essential in optimizing the patient's care pathways and their outcomes. This is the emergency department of the Yangon General Hospital, and this is the old building of our hospital. And this is the our entrance of the emergency department. And actually, emergency department, it is the integral unit of the hospital, and previously also known as the Accidents and Emergency Department, A&E. And some are also known as the ERC, Emergency Resuscitation Center. However, nowadays, they are commonly known as the Emergency Department worldwide. It is the front line of the hospital. ကျွန်တော်တို့လူနာမှန်သမျှအရေးပေါ်လူနာမှန်သမျှရဲ့ဝင်ပေါက်ပေါ့နော်အဲ့တော့အရေးကြီးတဲ့လူနာတွေအသက်လူပြီးတော့ကုရမယ့်အခြေအနေတွေအားလုံးရှိသမျှ medical surgical orthopedics gynecological ပါသေးတယ်တခါလေကလေးမွေးရတာပါပါသေးတယ် and toxicological emergency and oncological and life saving procedures အားလုံးရဲ့ဝင်ပေါက်ကဒီ department ဖြစ်ပါတယ် and this is the initially we triage the patient who is very much important and need immediate treatment, and other people have to wait for some hours. And this is the triage areas of the emergency department. And normally, triage process of the patient is three types: where patients needing the immediate treatment within minutes by the doctor and his trauma team. And category 2 is orange. Orange color is patients who need treatment within the 5 to 10 minutes. And lastly, yellow patients, they can wait for several hours. This is the internationally accepted patient stay in our department. And as for the emergency department in Yangon General Hospital, we also obey this range of the waiting time. And this is the entrance room. After triage, patient was placed to the treatment area. And this is the inside of the treatment area. And this is the always busy condition of our department. And this is the entrance of our department. And this is the resuscitation room. And sometimes some other countries call the shock room. This is the procedure of the CPR resuscitation procedure while we are saving the patient's life. And this is the showing the CCTV arrangement of our resuscitation room. And normally, most of the country are provided with this CCTV recording for the review of the patient's treatment. And normally, in our emergency department, normally, around about 16 specialties are needed for treatment of the emergency patients. Here, this is the internationalized recommendation of the 16 specialties needing the treatment of the trauma patient. And this is a situation where trauma team code is trauma resuscitation code is call for the following conditions, like the penetrating injuries of the neck and trunk, gunshot injuries, fracture of more than 2 proximal bones, unstable thorax and unstable pelvic fracture, amputation of the proximal to hands and feet, and injuries with the neurological signs of paraplegia and open cranial injury, and bands of more than 20% of the grade more than a 2B. This is our walking force. You can see scrub suit of the color of the scrub suit. It is the dark blue, and other people with the scrub suit of the sky blue and other color. So what are the available services in patients management at the moment? Mostly our service is 24/7 service of the emergency physician with his team, on-duty surgical team, orthopedics team, and on-call neurology surgeon, chest surgeons, cardiac, in other words, vascular surgeon and renal surgeon, and also the maxillofacial surgeons. And also 24/7 imaging services providing the patient management, and 24/7 lab services, and 24/7 social services, and also 24/7 running emergency operating theater. So roughly, I would like to present the trauma perspective of our department. Average number of the trauma cases per week. It is about 15 to 20 cases per week as a category 1 patient, that is red category. And normally, initial resuscitation of trauma patient is done by our emergency specialty, and subsequent management is followed by relevant teams like the surgical team, maybe thoracic team, neurological team, etc. And also, patient referral is done only after initial stabilization of the patient. Normally, category 1 red patients are treated immediately within a few minutes. And real-time assessment, that is a ABCDE approach normally. This is a some picture of the trauma patient visited to emergency department. This is a through and through injury of the patient and his chest X-ray. And this is the injury of the patient, stab wound, penetrating injury of the lower part of the middle of the neck. And this is the penetrating injury of the iron rods, need immediate resuscitation and trauma care. His X-ray. This is the penetrating injury of the iron rod. This is also another picture. And this is the open abdominal wound and incise wound of the eyeball of the patient. And this is the very severe injury of the on the right side, or on the left side. This girl is a high school girl. This incident was a road traffic accident last year, and she is a motorbike rider, and there's a run over injury over the abdomen, and there is a very severe fracture of the upper shaft of the femur, and you can see the fracture site of the upper part of the left femur. However, luckily the patient is at the time is conscious, well conscious. However, she is afraid of injury, and at that time we have the readily availability of the orthopedic team, and we can save the patient's life and also follow by appropriate operating procedure. So regarding the evolution of the trauma resuscitation practice, and rule of the practice is based on the principle of the advanced trauma life support procedures. Although there are diverse international settings, basic is the ABCD approach. It is supported by primary trauma care training courses and damage control resuscitation practice, permissive hypotension, and balanced transfusion approaches represent the example of the contemporary strategies. And these practices aim at mitigation of the deleterious effects of the hemorrhagic shock and optimizing the hemostasis. Regarding overview of the trauma care, there is a trauma care pyramids, namely the prevention, pre-hospital, standard of the pre-hospital care, and emergency department management, and definitive care and rehabilitations. And goals of the management are to save the lives, to prevent the secondary injuries like the hypovolemic shock and metabolic acidosis, and etc., and also stabilize for definitive care. And normally, modern principle of the trauma management is, as all you know, airway with spine protection, and it is A, and B is a breathing and ventilation. C is a circulation with hemorrhage control, and D is a disability. This is the assessment of the neurological status by GCS scoring, and E is exposure and environmental control. And however, there's a special considerations in trauma management, and they are the pediatric trauma management. There's a differences in anatomy, physiology, and fluid management. And geriatric trauma, there's a high risk of the complications due to their comorbidities. And pregnancy trauma, we need to prioritize the maternal stabilization while considering the fetal well-being. And there's some difference in treatment of the penetrating versus blunt trauma. And there's a team approach. Team approach is very much important, and communication is also important in the treatment of the trauma patient. Team member must be specific, dedicated roles, and otherwise the treatment of the trauma patient will not be appropriate treatment. And effective communication is so important, and use of the closed loop communication and SBAR, and simulation of the drills. So these are provided by the regular courses of the trauma management. And regarding about the trauma care training courses, there is a mainly ATLS, Advanced Trauma Life Supports and Primary Trauma Care courses, and also courses for master students, and they are given to the senior nurses. And other courses are instructor courses of the ADLS and primary trauma care courses. And additional supportive courses are also provided, like basic surgical skill training courses. And this is a cooperation with the surgical department, and our master students are also involved in these training courses. And other courses include the trauma and wound care workshops, like the wound care workshops. They are occasionally provided in the University of Medicine 1. And sometimes we also provide the point of care ultrasound training, like the EFAS and FASTScan, etc. And in the modern era, ultrasound became the stethoscope of our daily practice. So ultrasound is provided as a handheld size and conventional modern ultrasounds. Sometimes 3D dimensional ultrasound are also available. This is the primary trauma care course for master students. It is regularly provided in the University of Medicine 1 training scale-up center. This is airway management and cardiac arrest care. And this is the candidates accomplished the certificate of the primary trauma care. Regarding the human resources and treatment materials, and unfortunately, we have still limitations. We have only 33 emergency physicians in the Myanmar, and need to do a knowledge sharing and persuasion of the junior doctors and nurses, because our training and our workload is demanding, and we need some new blood to be involved in our department, and needs to promote the development of the emergency departments in other hospitals also, both the district and townships level. Moreover, overseas training are also key program for both doctors and nurses. Pre-hospital trauma care, it is also important integral part of the trauma care vision. So there are also the weak points present, and continuation of the trauma resuscitation begins with the pre-hospital care. And it emphasizes the importance of timely and efficient intervention in the field of the emergency care. And innovation, including the use of the advanced life support measures and telemedicine, and contribute to improve the patient's outcome upon arrival at the trauma center. ကျွန်တော်တို့ရှိမှာကတော့ဒီ trauma care ဆိုပေမဲ့လည်းသူရဲ့ initial treatment ကတော့ pre-hospital care ပါ။ဆိုတော့ pre-hospital care ကောင်းဖို့ကြတော့လေကျွန်တော်တို့ကအဲ့ဒီ pre-hospital care ကိုစောင့်ရှောက်ပေးမဲ့basic health care worker တွေကိုလည်း training လုပ်ပေးဖို့လိုပါတယ်။ကျွန်တော်တို့ကဆေးရုံမှာထိုင်ဆောင်နေတယ်ဆိုရင်တော့လေဒီ trauma care ကပြည့်စုံတယ်လို့ပြောလို့မရပါဘူး။ trauma care က initially pre-hospital care ကစတာဖြစ်တဲ့အတွက်ကြောင့်ဒီ pre-hospital care ကိုလုပ်မဲ့health care workers တွေကို training ပေးတဲ့service ကလည်းကျွန်တော်အရေးကြီးတဲ့ program ထဲမှာပါပါတယ်။ဒါကိုကျွန်တော်တို့ first responder course လို့ခေါ်ပါတယ်။ဒီ course ကတော့ကျွန်တော်တို့အခါအားလျော်စွာနေပြည်တော်မှာပေးတာရှိတယ်။နေပြည်တော်က basic health care workers ကိုပေးပါတယ်။နောက်တစ်ခုကRed Cross Society MRCS နော်ကျွန်တော်တို့မြန်မာပြည်ရဲ့ချက်ချင်းနေတင်နန်းသားပေါ့နော်တင်နန်းချက်ချင်းနေအဖွဲ့အလူတွေကိုလည်းပေးပါတယ်။ဒါသူတို့ကိုကျွန်တော် first responder course မနေ့ကပေးခဲ့ပါတယ်။ဒါနေပြည်တော်ကချက်ချင်းနေရုံးချုပ်မှာပေးခဲ့ပါတယ်။နောက်သူတို့က certificate တွေရပါတယ်။သူတို့ကိုလည်းကျွန်တော်တို့က TOT လည်းပေး TOT ပေါ့နော်ကျွန်တော် training of trainers course လည်းပေးခဲ့ပါတယ်။ဒါကတော့စုစုပေါင်းအဲ့တုန်းကတော့ကျွန်တော်တင်နန်းသား candidates 36ယောက်ကိုပေးခဲ့ပါတယ်။ And regarding the evidence-based practice in trauma management, everyကျွန်တော် Monday တိုင်းမှာကျွန်တော်မနေ့8နာရီဆို audit လုပ်ပါတယ်။အဓိကတော့ဒီ trauma death တွေကိုကျွန်တော်တို့က emphasize လုပ်ပြီးတော့ cause of death နော် cause of death ကဒါကတည်တဲ့လူနာလားဒါမှမဟုတ်ကျွန်တော်တို့ inappropriate treatment ဒါမှမဟုတ်ရှင်လဲ timely referral မဟုတ်လို့လားနော်ဒါမှမဟုတ် timely referral ကျွန်တော်တို့သဘောတော့ဒီ golden hour ရှိပါတယ်။ trauma တစ်ခုမှာ golden hour အတွင်းမှာကုသမှုမပေးနိုင်ရင် trauma death ကဘယ်တော့မှမကြပါဘူး။ဒါကြောင့်ကျွန်တော်ကဒီ human factor လားเนาะ time factor လားဒါမှမဟုတ်ရှင်လည်း very severe injury เนาะ head injury လည်းပါတယ် limb တွေကလည်း fracture ရှိတယ် intraperitoneal bleeding နဲ့ shock ကြောင့်ဆိုရင်လည်းကျွန်တော်တို့ဒါကိုအများအား analysis လုပ်ပါတယ်ဒါမှမဟုတ် lesson plan ကိုလည်းကျွန်တော်တို့အများအားလေ့ကျင့်ပေးနေပါတယ်နောက် regular journal reading လုပ်ပါတယ်နောက် monthly clinical meeting ကျွန်တော်တို့ရန်ကုန်ဆေးရုံကြီးက monthly clinical meeting ကိုလည်းတက်ပါတယ် so ကျွန်တော်တို့ is YGH a perfect trauma center is it a perfect not yet မဟုတ်သေးပါဘူးကျွန်တော်တို့ hopefully trauma center တခုတည်ဆောက်မယ်တဲ့အစီအစဉ်တော့ကျွန်တော်တို့ကြားသိရပါတယ်တေချာတော့ plan လုပ်ထားတော့မသိသေးပါဘူးကျွန်တော်တို့ specialist hospital ဘေးမှာနေရာလို့ရှိတယ်လို့ကြားပါတယ်အဲ့တော့မနေ့ကတော့ကျွန်တော်တို့ဆေးရုံအုပ်ကသတင်းတစ်ခုပေးပါတယ်အဲ့နေရာမှာ trauma center တခုစောက်မယ်လို့တော့သူတို့ plan ရှိတယ်လို့ပြောပါတယ်ဒါကတော့ financial အရာပေါ့နောက်နှစ်အခုလာမယ့်နှစ်အတွင်းမှာဖြစ်ချင်းလည်းဖြစ်နိုင်ပါတယ်နောက်တစ်ခုကျွန်တော်တို့က trauma surgeons မြန်မာပြည်မှာကျွန်တော်တို့ trauma surgeon ရှိလားလို့မေးခဲ့ရင်တော့ကျွန်တော်ဖြေရမှာတော့ trauma surgeon လို့တော့မရှိပါဘူးကျွန်တော်တို့ general surgeon တွေကပဲရှိသမျှ trauma တွေကို splenectomy လုပ်လို့လိုရင်လည်း splenectomy လုပ်ပေးတယ် neurosurgeon က EDH SDH ကို evacuate လုပ်ပေးတယ် thoracic surgeon ကလိုအပ်တဲ့ thoracic surgery နောက် vascular surgeon က vascular injury ဒါမှမဟုတ်ရှင်လဲ pericardial tamponade ကိုသူက train လုပ်ပေးပါတယ်ဆိုတော့ဒီမှာကတော့ကျွန်တော်တီးတီးတဲ့ trauma surgeon ကတော့ညီမပြည်မှာမရှိသေးပါဘူးဒါပေမဲ့လို့ကျွန်တော်တို့ပြီးခဲ့တဲ့2014ခုနှစ်ကချင်းမိုင်မှာကျွန်တော်တို့ surgeon 20ကျော်လောက်ကိုတွားပြီးတော့ silent mentor ဆရာတို့မင်္ဂလာတုံက training လုပ်နေတဲ့ program လိုပဲ silent mentor ကျွန်တော်တို့10ရက်2014က10ရက်အမှဆရာတွေအကုန်ပါပါတယ်ကျွန်တော်ပါတယ်နောက်ဆရာဦးမြတ်သူပါပါတယ်ဆရာဦးမြတ်သူနော်ဒီကဆရာကောင်းမြတ်ပါပါတယ်နော်သူတို့အားလုံးအမှ silent mentor training လုပ်ခဲ့ပူပါတယ်နောက်တစ်ခုကကျွန်တော်တို့လိုအပ်တာတွေက regular ATLS နဲ့ PTC courses တွေနော် regular လုပ်ဖို့လိုပါတယ်နောက် health education of public ပေါ့နော် prevention of the trauma နော် especially road traffic accidents challenges ပေါ့ကျွန်တော်တို့ emergency department အနေနဲ့ challenges တွေကတော့ definite trauma center မရှိပါဘူးကျွန်တော်တို့ကလောဆယ် emergency department မှာပဲ trauma တွေကုပေးနေပါတယ်နောက်တစ်ခုကတော့ trauma network တခြားနိုင်ငံတွေမှာတော့ရှိပြီးသားပဲကျွန်တော် trauma တစ်ခုလာမယ်ဆိုရင်ကြိုတင်အကြောင်းကြားတယ် call center ကိုအကြောင်းကြားတယ်ကျွန်တော်တို့က trauma team ကကျွန်တော်ခုနပြောတဲ့16မျိုးလောက်ပါတယ် trauma team က ready စောင့်နေတာရှိပါတယ်နောက်တစ်ခုက human resources တွေကျွန်တော်တို့စုဆောင်းဖို့လိုပါတယ်နောက် continuous trauma training နောက်တစ်ခုကတော့ standardized diagnostic and therapeutic algorithm ဒါလောဆယ်တော့ကျွန်တော်ရှိမှာမရှိသေးပါဘူးနော်နောက်တစ်ခုကတော့classification of severe trauma trauma တခုကဘယ်လောက် severe ဖြစ်တယ်လဲလူအများကြီးလိုမှဒီ trauma ကကုသလို့ရမှာလားဆိုတော့ severity assessment normally ကတော့ကျွန်တော်တို့ကတော့ mild moderate severe နဲ့သွားနေပါတယ်တကယ်တမ်းကျတော့ဒီ injury severity scoring နဲ့သွားပါတယ်ဒီအထိတော့ကျွန်တော်တို့ကအသေးစိတ်trauma assessment ကိုမလုပ်နိုင်သေးပါဘူးနောက်တစ်ခုကတော့ standard pre hospital care practice ကလည်းအားနည်းနေပါသေးတယ်ဒါတဖြည်းဖြည်းကျွန်တော်လေ့ကျင့်သွားဖို့လိုပါတယ်နောက်တစ်ခုကတော့ cooperation within the acute hospital and rehabilitation facilities ဒါတော့ကျွန်တော်တို့နောက်ဆုံးလူတစ်ယောက် amputation လုပ်လိုက်ရတယ်မတတ်နိုင်ဘူးကျွန်တော်တို့ပြန်ပြီးတော့သူရဲ့ rehabilitation အတွက် prosthesis လိုရင်လုပ်မယ်နောက်ကျွန်တော်တို့အဲ့ဒီ physiotherapy เนาะစသည်ဖြင့်ဒါတွေလိုပါသေးတယ်ဒီပုံလေးကတော့ဂျာမနီကပါဂျာမနီမှာဆိုရင်တော့ကျွန်တော်တို့ဒီ emergency department ပေါ့เนาะဒါ the trauma center 600ရှိရလို့ပြောပါတယ်တော်တော်လေးများတယ်เนาะအရေးအတွက်ပါကျွန်တော်တို့ further plan တွေရှိပါတယ်ကျွန်တော်တို့ trauma care training ပေါ့ emergency physician surgeons လုပ်ပေးရပါမယ်နောက်တစ်ခုက promote the development of the dedicated trauma center เนาะဒါ stakeholder တွေလုပ်ပါလိမ့်မယ်နောက်တစ်ခုက well equipped emergency resuscitation room in hospital nationwide เนาะ national wide ပြရပါမယ်နောက်က medical cover for sports and sport medicine development ဒါတော့ sport medicine ကိုတိုးတက်အောင်ကျွန်တော်လုပ်ပေးဖို့လိုပါမယ်နောက် rehabilitation ပေါ့ဒါကတော့ခုန prosthesis နဲ့ rehabilitation program တွေကိုညှင့်တင်ပေးရပါ key message အနေနဲ့ကတော့ diagnostic and treatment ကတော့ဒီ resuscitation room မှာရေးကြည့်ပါတယ်နောက်တစ်ခုက short room procedure တွေကိုကျွန်တော်တို့ standardized specific training လုပ်ပေးဖို့လိုပါတယ်နောက် surgical hemostasis တော့အခါလေးကျတော့ဒီ patient တွေကကျွန်တော်စောင့်လို့ရတဲ့ shock ရှိတယ်စောင့်လို့မရတဲ့ shock ရှိတယ်ပေါ့နော်တခါကျတော့လည်း open လုပ်ဖို့လိုပါတယ်နောက် target systolic blood pressure ကျွန်တော်တို့ဒီ ဒီမှာကတော့80 to 90ဆိုပေမဲ့လည်းဒီ head injury နဲ့တွဲနေရင်တော့80 mm mercury ထက်နည်းနည်းတိုးပေးပြီးတော့တင်ပေးထားဖို့လိုပါတယ်နောက်တစ်ခါ liver injury cases မှာတော့တစ်ခါကြောက်လဲ conservative treatment ကတော့90%ရှိပေမဲ့31%ကတော့splenic trauma မှာကျတော့31%ကသူက conservative treatment 31ရာခိုင်နှုန်းပဲ conservative treatment ရပါတယ်summary အနေနဲ့ကျွန်တော်ဒီ trauma resuscitation practice တွေကိုကျွန်တော် promote လုပ်ရပါမယ် multidisciplinary collaboration လုပ်ပါမယ်နောက် advanced monitoring techniques in resuscitation လုပ်ပါတယ်နောက်က innovation of the pre-hospital trauma care and contemporary resuscitation strategies now evidence-based practice and challenges and opportunities in trauma resuscitation and နောက်တစ်ခုကတော့ trauma center network เนาะဒါပေါ်ဖို့လိုပါတယ်နောက်တစ်ခုကတော့ trauma prevention projects ဒါတွေကတော့ဒီ stakeholder တွေကကျွန်တော်တို့ကူညီထောက်ပံ့ပေးဖို့လိုပါတယ် so injury prevention projects တွေကတော့ကျွန်တော်တို့ဒီ auto ဆရာဝန်တွေအနေနဲ့ကတော့ orthopedics department ကတော့လောက်တာတွေ့ရပါတယ်เนาะ program တွေလည်းရှိတယ်လို့တွေ့ပါတယ်
Thank you, Professor Windsor, for the very informative presentation and the very interesting picture. The Q&A section will be after that speaker. Thank you, sir. Now we will go on for the next speaker, Professor Sanyi. He's a well-known surgeon from the Yangon General Hospital and the ward in charge of the surgical ward 3. He has around about 20 years experience of the both emergency and elective surgery, including the abdominal trauma surgery. So please call upon the Professor Sanyi to present the abdominal trauma still magic box. Okay. မိချိန်လာဆောင်နေလေကျွန်တော်တို့ any question from the audience for the Professor Windsor for the current trend of trauma management in emergency department of the YGH ကျွန်တော်တို့ချိန်လေးလေးဟိုနောက်ဆုံးချိန်လေးဖြစ်နေတော့လေအချိန်ကို save ဖြစ်တဲ့အနေနဲ့မိချိန်လာရှိ any questions from the audience ဒါတော့ပြိတ်ပါလေ
It is a very good question. It is raised by my professor head of the research department. It is difficult to answer the question because by myself is only a general surgeon who is practicing the emergency specialty. So I am not a trauma surgeon, and also only there's some part of our at the moment only about I think well trained for the emergency situation, so-called trauma surgeon is not in Myanmar at the moment.
Thank you, sir. Now, Professor Singh will be present abdominal trauma, still magic box.
Thank you, Mr. Chairman, for your kind introduction. Good afternoon, ladies and gentlemen. It is a great pleasure for me to be here with all of you to take part in this symposium. First of all, I would like to say my special thanks to Professor Domomodin to give me such a great opportunity to discuss on abdominal trauma. Trauma is neglected epidemic of modern society. For the doctors, especially for surgeons, trauma is kind of like something we have to know and manage well. As trauma, incidents, and violence are significant causes of death. In today's talk, I would like to explore what are the types of abdominal injury, why they are important, and how can we minimize trauma-related mortality and morbidity. In this picture, you can clearly see that road traffic injury is major cause of injury death in 2019, which is about 29%, maybe due to a modern lifestyle. People are moving too rush to take care of road traffic rules and regulation. Second most is secondhand, which is about 16%, maybe due to stressful life in modern life. The third most is due to falls, maybe due to occupational hazards or elderly associated morbidities. Let's have a look at how heavy the burden of trauma to us. Trauma is one of the top 10 causes of death. 8% of all years live with disability as a consequence of trauma. 4.4 million dead in 2019 due to trauma. For the age 5 years to 29 years, top 3 causes of death are injury-related, such as road traffic injuries, homicide, and suicide. 1.25 million dead in road traffic accidents. There is quite a lot of lives. And 1 billion patients are seeking medical assistance after an injury every year. Regarding with injuries, I would like to discuss a very important point. There is a trimodal distribution of death. It is first described by Turkey in 1983. After the trauma, there are 3 distinct peaks of trauma-related death, which are first peak or immediate death occurs within the first hour, maybe due to non-survivor injuries. Second peak, also known as early death, occurs 1 to 4 hours after the injury and may be due to head, chest, and abdominal trauma. The third peak occurs within the 1 week and may be due to multi-organ failure or sepsis. This model is quite significant because by understanding the different phases of trauma-related death, we can allocate the resources and can use specific strategies in trauma care. Abdominal trauma can be classified into blunt and penetrating trauma. They have different presentation and different management. Blunt trauma is most common type of abdominal trauma. Some of the examples of blunt trauma are motor vehicle accidents, pedestrian strike, falls, assaults, and sports-related injury. We should clarify ourselves what trauma surgery is. There is a great saying, trauma surgery is general surgery, under stress and bleeding. It's evolved tremendously over past 50 years. In a traditional belief, previously we believed that there must be mandatory exploration for all penetrating wounds. but now it has been changed dramatically because of advance in imaging techniques. Now, we can go with selected non-operative management in neck and abdominal trauma. In trauma patient, we have to do primary survey, secondary survey with some imaging techniques whenever necessary. Our clinical judgment will decide which investigations we should do. After the trauma, primary survey is very important. As soon as patient gets into our hand, the first thing we need to do is the primary survey. If it is to be done within the first hour, it can be said the golden hour. If we can do the definitive measures within this period, we can change the outcomes of the patient. The primary survey is ABCD approach, which is well known by all doctors. Together with primary survey, we have to consider the FAST scan. FAST scan is very sensitive and as well as very specific. It can detect hemoperitoneum or hemopericardium very rapidly. But keep in your mind that negative FAST scan cannot exclude bleeding. Please do not forget to do pregnancy tests for all childbearing female patients. In secondary survey, your history must be brief because trauma case is urgent and time is ticking. But your history must include pre-existing conditions or medication that alter our management. This is a clear, concise algorithm for investigation of blunt abdominal trauma. After the secondary survey, if the patient is stable, we'll proceed to CT scan. If CT scan shows intra-abdominal injury, we have three options. They are observation, angioembolization, or laparotomy, depends on extent and severity of the injury. If the patient is unstable, we proceed to ultrasound. If ultrasound reveals free intra-abdominal fluid, we'll go to laparotomy. If there is no free intra-abdominal fluid, we have to look for other causes of hypoperfusion. As I mentioned before, FAST scan is very useful, and now FAST scan is regarded as extension of trauma clinical assessment. We commonly use CT scan, whole body CT scan or PAN scan. It is now regarded as gold standard for trauma imaging. Some of the indications for CT scan are high-speed motor vehicle accidents, non-trivial motorcycle collision, death at the scene, fall from height more than 2 meters, abnormal fossa X-rays, and abnormal vital signs. Diagnostic peritoneal lavage is less useful and no longer standard diagnostic procedure because of advance in imaging techniques. What about the diagnostic laparoscopy? It can be used not only for diagnosis, but also for therapeutic procedures. Requirements are patient must be hemodynamically stable. There's absence of indication for urgent laparotomy, and surgical team must have experience in laparoscopy. Contraindications are diffuse peritonitis, evisceration, penetrating anal or vaginal injuries, and so on. Another important point I would like to discuss is the LEADER trial, which comprise hypothermia, acidosis, and coagulopathy. These three factors form a vicious circle that can lead to rapid decline in patient condition, eventually resulting in death. So we must prevent the onset of LEADER triad as soon as possible. Otherwise, very difficult to combat later. In addressing to LEADER triad, we have to do damage control surgery. The aims of damage control surgery are to stop bleeding, to limit contamination from intestine without restoration of the anatomy, and normalize the pathophysiological parameters in the ICU. Indication for damage control surgery are anatomical, physiological, and environmental indications. There are 4 phases of damage control surgery. Phase 1, abbreviated surgery. Phase 2, ICU care. Phase 3, repair of all injuries and late reconstruction if possible. Now we move on to solid organ injuries. Common solid organ injuries are liver, spleen, kidney, and diaphragm. Liver injury can occur after both blunt and penetrating trauma. 85% of liver injury found not to be bleeding at the time of surgery due to low pressure venous system within the normal liver parenchyma and tamponade effects of the ligament. So we prefer non-operative management, but it depends on clinical findings and severity of the injury. Liver injury can be classified into grade 1 to grade 5 depending on CT features. During the laparotomy, for the simple lacerations, we can use topical hemostatic agents, organ coagulation, or electrocautery to stop the bleeding. For larger lacerations, we can suture or sometimes we fill the parenchyma defect with ometem if hemorrhage persists. Vascular isolation or liver can be done by Pringer's maneuver. Non-anatomic liver resection is more preferable than the anatomic liver resection for distracted parenchyma injury. Splenic injury can also be classified into grade 1 to grade 5, depending on CT features. There's revolution in treatment for splenic injury. Because of advance in imaging techniques and high success rates with the help of angioembolization. During the laparotomy, we have to mobilize the spleen medially by odd maneuver to look the extent and severity of the injury. For larger lacerations, we can repair with absorbable sutures. Sometimes we need to do emergency splenotomy in case of non-salvageable splenic injury. Sometimes autotransplantation of spleen may be tried, but with less evidence of success. Kidney injury can also be classified into grade 1 to grade 5 depending on CT features. Diaphragmatic injury can occur in high energy acceleration deceleration trauma or direct laceration from a weapon or broken rib. Left-sided injuries are more common, but right-sided injuries are more severe. If delay in diagnosis, that can lead to respiratory distress or herniation of intra-abdominal organs into the thoracic cavity. We can repair the diaphragmatic injury with non-absorbable interrupted sutures. Sometimes we can use prosthetic material such as Prolene mesh to repair the defect. Let me talk about the hollow organ injuries. Common hollow organ injuries are stomach, duodenum, small bowel, and large bowel. Small stomach injury can occur following penetrating trauma. During laparotomy, we have to do careful evaluation of diaphragm, esophageal hiatus, and both anterior and posterior wall of the stomach. Urinary injury can be classified into extent of laceration, site of involvement, and associated organ injuries such as common bile duct, pancreas, or vascular involvement. Small intestinal injury can occur in 15 to 20% of blunt trauma, maybe due to crushing between the spine and blunt objects. Sometimes closed loop rupture can occur because of sudden increase in intra-abdominal pressure. Small intestinal injury can occur in 25 to 30% of penetrating trauma. It may be direct laceration in low velocity and high velocity mechanisms. Large bowel injury is mostly due to penetrating trauma. It can only occur in 5% of blunt trauma because colon is refractory to blunt trauma. For your diagnosis, digital radar examination is essential and you can see the blood on your finger. There must be high index of suspicion in pelvic fracture, penetrating injury to lower abdomen and buttock. If there is delay in diagnosis and initial treatment of radar injury, the morbidity is high. Colonic injury can be classified into grade 1 to grade 5, depends on extent of laceration and vascular involvement. For bowel injury, damage control techniques are skin staple closure, rapid single layer closure, or staple discontinuity. Retroperitoneal injury can be divided into 3 zones. Zone 1 or central zone. As you see, the great vessels are cross that area and you have to explore that area. In zone 2 is the two lateral zones, and it should be explored only when there is expanding hematoma or penetrating injury. Zone 3 or pelvic zone, whenever possible, should not be explored. There are 4 essential parts in trauma laparotomy. They are control of major hemorrhage, identification of all injuries, control of contamination from bowels, and reconstruction if possible. They are the examples of clinical cases, but I will skip because of time limitation. Okay, let me summarize my presentation. Trauma is the disease of all age. There are many variables in an abdominal trauma together with complex or combined injuries. Therefore, abdominal injury stays a magic box with variable diagnosis. For your take-home message, what is the key to open that magic abdomen? Whatever it is, the key to open the magic box is surgeon knowledge, experience, and skills to create miracle result for our trauma patients. Thank you. Thank you for your kind attention.
Thank you, Professor Sai, for the very precise and informative presentation. The Q&A session will be the after that speaker. Now I will call upon the Dr. Pyo Wen. He is a consultant surgeon in the Department of the Pediatric Surgery, number 1, Defense Service OG and Children Hospital, Yangon. We are going to present the impact of the pediatric trauma, the right of the child to be protected. Please, Dr. Pyo Wen for the presentation.
Thank you, Mr. Chairperson, and thank you for the organizing committee chairperson and all the members, and giving me a chance to present this topic in this trauma symposium. I'm Dr. Pyo Wen, head of department from the Department of Pediatric Surgery, Defense Services OG and Children Hospital. So today, I would like to discuss the topic about the impact of pediatric trauma at the right of child to be protected. To save the time, my presentation will be short to the point, especially particulars for the pediatric patients and the pediatric population. This is the outline of my presentation. So as the Professor Sang mentioned earlier, the trauma is a leading cause of mortality also in children. So in the United States, 11,000 deaths. For the globally, more than 650,000 deaths annually, and nearly 13 million non-fatal injuries due to the trauma in 2015. In the studies, 1 to 19 years of age are included. And it is also second leading cause of death even in infants. So in our practice, nearly 300 trauma cases in Myanmar. That's especially Yangon Children's Hospital and our hospital. So of these, nearly 50% are the band and skull injury, because band and skull pediatric special unit is ran in our surgical units of the Yangon Children's Hospital. So nearly half of them are band and skull patients. And then 1/4 are associated with the head injuries. And then the others are the blunt abdominal injuries. And the others are the minor injuries like the cuts and lacerations. So the hemorrhage is a leading cause of preventable death, and 80% have associated head injury, and 80 to 90% are the blunt trauma. Furthermore, the significant psychosocial impact on the children and caregivers So in here, I wanted to highlight the universal right of a child. So according to the United Nations Convention on the Child Right, it is stated that in the altogether 54 articles state that the right of child to be protected. So these key principles include non-discrimination, best interest of the child, the right to life, survival and development, and respect for the views of the child. So according to Myanmar status, Myanmar became a signatory to that convention since 1991. And we have the law, that is the Law, law number 22, enacted in 2019. So we have to protect the child according to the law. So here, the differences of the child to the adult. So as you all know, that anatomically and physiologically, cognitively and psychologically, the child different from an adult. They had a larger head, so traumatic brain injury is common. The upper spine, cervical spine injury is more common than the lower cervical spine injury. And they have a smaller airway, oblique nose breather, so they can rapidly compromise. And for example, like in the nasal fractures. And they has the less well-protected chest and less well-protected abdomen. So this can cause to the internal organ injuries, even in the blunt trauma. But to the good side, they have the cartilaginous nature of the bone, and that prevent to some extent for the fractures. So how the children are injured? So most of the person here have the children, and will have had the nursery rhyme like that. 5 liters monkey jumping on the bed. One fell off and bumped his head. So like that. So mama called the doctor, and doctor said, no more monkeys jumping on the bed. So like that, the children are at risk of the proportion to their level of cognitive, physical, and social development. So for the 3 to 5 months of children, they roll. They grasp all the objects and placing them into their mouth. So for my own experience, I have one daughter. She was 3 months of age. She rolled from the table and fall off from about 4 feet height, got head injury. So we so much worried about that, and we ran to the neurosurgeon. But fortunately, nothing serious happened. But all the patients are worried so much about their children for their injury. So for the 8 to 12 months of children, they cruise around all the furnitures and pull down everything they can help and cause the trauma, pain, and score at age. So for the preschoolers, they have the increased mobility and curiosity, and they cause of falls, pans, and intentional ingestions. And for the school-age children, they actively play like cycling and climbing. So they fall from the playground equipment like the trampolines. So for the older children, as mentioned earlier, road traffic accidents are more common, and then assaults, bullying, and intentionally self-harm and intoxications. And furthermore, like in United States, school shootings, gun firing accidentally. And for some countries like Africa and our countries involved in the armed conflict and got injury from there. So there's a quick review of ABCs for the children. So children usually have the difficult airway. So securing airways fight attacks, especially for the less than 1 year of age. They have a larger head, prominent occiput, and shorter neck, larger tongue, shorter mandible, and obligate nasal breathers that lead to difficult airway. And also, adenoids and tonsils may be prominent. Hypopharynx is relatively shorter and narrower. Larynx is relatively higher. And the crack ring is located at the level of C4 at birth, C5 at the 6 years, and C6 as adult. And also the vocal cords are angled anterior inferior to posterior superior. So this can make the insertion of endotracheal tube more challenging. Epiglottis is more U-shaped. So we have to use a semi-straight laryngoscope blades, Miller, than Mason dot. And also the flexible cartilaginous rings predisposed to the dynamic obstruction, especially when it has a partial obstruction of the trachea. So the airway management is key, and pediatric patients have significant differences, and awareness, knowledge, and available airway techniques and tools are needed for safe and effective management of the pediatric airway. Also, according to the physiology, they are prone to hypoxemia. Oxygen consumption is higher relatively, 6 ml per kg per minute, and they have the lower functional residual capacity, lead to the rapid desaturation. A carbon dioxide production is also more than adult, but the tidal volume is relatively constant, so they have a rapid respiratory rate. For the circulation shock, they have the less volume, but relatively larger reserve. So the blood pressure may remain normal until they lost 40 to 50% of their blood volume. So the tachycardia is often the first sign of shock. So here, according to the age group, the respiratory rate, heart rate, and the blood pressure, so we can see so much different from the 3-month child to the 12-year child. So the vital signs should be kept in mind. Also, the IV access for the children is challenging, and it is important to obtain the IV access after arrest of hemorrhage. So we have to use a proper use of cannula, CVB lines, and venous cut-down. So for emergency condition, we can use the intraosseous access. These are the different types of intraosseous needle, can, and different needles. So here, I would like to highlight trauma-induced coagulopathy here. So for the trauma-induced coagulopathy, it's a complex process resulting from tissue injury, ischemia, further exacerbated by dilution, acidosis, and hypothermia. So the component blood therapy are more popular and appropriate for the resuscitation for the child. So the coagulation monitoring is more required than the conventional coagulation tests like the PT, PTT fibrinogen, and the newer tests like the thromboelastography, rotational thromboelastometry, and the impedance aggregometry. So the goal is we give the back RBCs 10 to 15 ml per kg to increase the hemoglobin from 2 to 3 gram per deciliter. For the platelets, 5 to 10 ml per kg, increase the platelets of 50 to 100,000 per cubic millimeter. So FFP precipitates are also appropriate for the resuscitation. So the target is we have the goal of 1:1:1 ratio of the RBC to FFP to platelets. So then newer components are the factor concentrates. I recommended factor 7A, the prothrombin complex concentrate PCC, that's factor 9, and 3-factor PCC, like the factor 2, 9, 10, or 4-factor PCC, 2, 7, 9, 10. And also the tranexamic acid has a role to prevent the breakdown of the fibrin. So the appropriate dose will be beneficial for the pediatric patient. So according to the imaging in pediatric trauma, the CT scan is a very much useful tool, but the CT scan utilization in trauma patients is 3 million scans per year in 1980 and increased to 60 million per year in 2006. So the radiation exposure produced by the CT scan is not trivial. So we have to consider that radiation exposure. So because according to this retrospective review study, the mean dose for all children receiving the imaging, that is X-ray, CT scan, and others, have an average of the 12.8 millisievert plus or minus 12 millisievert. So the radiation dose of 50 to 60 milligray to head to bone marrow resulted threefold increased risk of brain tumors and leukemia in children. So the guidelines are being developed to limit the unnecessary radiation exposure, like the scoring system. So according to the scoring system, and we have stratified the mild, moderate, severe. For the only moderate and severe patients, go to the the imaging, and for the mild trauma patient, according to the scoring system, just wait and see. Regarding the traumatic brain injury, is most common fatal injury in children. After primary survey, evaluation for traumatic brain injury should include the complete neurologic examination, including GCS for children, like as mentioned, and pupil size, inspection of head and spine, anterior frontal fundoscopic and endoscopic evaluation required. Neuroimaging also, the CT scan is preferring imaging modality. And other valuable modalities include MRI and transcranial Doppler DCT. For the thoracic injury, relatively uncommon in children, but it is serious to cause a mortality. Because of the lack of a complete ossification of the ribs and sternum, it's less well protected. So the common injuries are the rib fractures, pulmonary contusion, pneumothorax, and hemothorax. And specific and severe injuries are tension pneumothorax, open pneumothorax, and cardiac tamponade. So association injuries, head, abdomen can increase mortality. So intra-abdominal injury, like mentioned earlier, is the third leading cause of pediatric trauma mortality. Most of the injury are the blunt mechanism, as I'm penetrating, and also the solid organ injury, liver, spleen, kidneys are more common than hollow organ injuries. The main monitoring is hemodynamic status. It is a better guide to go whether conservative management or the surgical intervention. So most of the blunt abdominal trauma, the non-operative management is successful. But the management, conservative management failure are seen in 3% of isolated liver injury and 4% of isolated spleen injuries. So the main cause of failure is hemorrhage, and that maybe benefit from the angioembolization for the spleen injury with the contrast extravasation. So also the renal injury, the conservative is preferable treatment, and endourologic stenting and angioembolization are also useful. And immediate surgical intervention is reserved for those with the hemodynamic instability. Pancreatic and duodenal injuries are more likely to require operative intervention. So burn and scald is a significant injury in the children, and also nearly 75% burns in children are preventable. So this is the algorithm for the routine burn injury management. Here I would like to highlight the major burn injury that needs a referral and admission to the burn unit. And the differences here are assessment of the extent and depth of the children, depth of the burn for the children. So we have that figure chart in the burn unit, and assessment of the extent and depth is important. So mainly, the prevention and precaution is important for the burn and scald. So increased use of smoke detectors. The products such as toys and pajamas children use should be regulated. The monitoring of fire safety in workplace and schools, and no smoking areas, especially around children and keep flammables and hot liquids out of reach of children. The child abuse is also an important topic here. According to the Article 19 of the CRC, the protection from the violence of the children is the government must protect the children stated in the article. So the non-accidental injury may be suspected in the delay seeking medical treatment. Inconsistency in the history provided, and history and mechanism of injury not consistent with the child developmental stage, and obvious caregiver impairment, such as an intoxicated caregiver, and allegation of non-accidental injury raised by the either caregiver or child. So these patterns are suggestive of non-accidental injury, like a bruising in a less than 9 months old child, bruising to the face, ears, buttocks, back, or hand, and bruising is like a shape of an object and ligature, and posterior with rib fractures, and multiple injuries with the fractures at the different stages of healing. So it's a repeated injury. And then when non-accidental injury is suspected, the reporting policies must be followed, consulting with a senior clinician, social worker, and forensic medical service, like a police case. So the child protection services need to be contacted to ensure the safety of the child or their siblings. So the pain management in children is also different. So pain assessment in children, which we use a scoring system, mostly for the neonates and infants, the CRI score, FLACC scores we use. And for the toddlers and young children, the physics pain scale, like a 0 to 10, and the older and adolescents, numeric rating scale is useful. So special consideration in pain management is age and body weight is important for medication dosing. Opioid use must be appropriate and monitor side effects of voice overuse. And multimodal approach is important, and pain assessment and management should be individualized. Continuous monitoring and reassessment is mandatory. So we usually use the acetaminophen and NSAIDs for the mild pain, and the opioid and nerve block for the moderate to severe pain. And ketamine and benzodiazepines are the adjunct medication for anxiety. Psychological impact is also important for the children because post-traumatic stress disorder can affect the children's cognitive development, emotional and social development. Anxiety, depression, and behavior problems are also found in children, leading to relationships, productivity, and mental health problems. So here are some prevention strategies. So it involves a combination of the education, environmental modifications, and policy changes. So at home, our homes should be child-proofing home. And also the close monitoring of your young children, especially around the water, roads, and the potential hazards. And education, teaching children about the safety practices and risks, they can learn very well. And also the legislation and regulation, like the laws, implementing and enforcing laws related to child safety is important, such as car seat regulation, pedestrian regulation, and playground safety standards. And community program initiatives aim to improving safety in communities such as swimming lessons and first aid training. So according to the CRC, the preventing strategies are also the responsibility of the government. So it should protect children from the sexual exploitation, being taken advantage of, and sexual abuse, including by people forcing children to have sex for money or making sexual pictures or films of them, according to the Article 34. In Article 24, children have right to the best health care possible, clean water to drink, and healthy food, and clean environment, safe environment to live. All adults and children should have information about how to stay safe and healthy. And also, no child under 15 can join the army or take part in war. And also, children have the right to get help if they have been hurt, neglected, treated badly, or affected by war, so they can get back their health and dignity. So, take-home message for this presentation is protecting children from the trauma is a not only moral imperative, but also the universal right of every child to live free from harm. So we should actively tell children and adults about this convention so that everyone knows about the children's rights. So these are the references. And here's my daughter, now 10, 4 years. And now she can read very well to the road sign and cross safely to the roads, leading her friends from the nursery school, going to the excursion trip of her school. And also, I wish all the children worldwide safe and sound. Thank you for your kind attention.
Thank you, Dr. Pyo Sin-win, for your very informative presentations. So, because of the time limitation, Q&A session will not be allowed. So before conclude this symposium, I would like to say thank you the presenters for their insightful contributions and participations. And also I wish you, especially surgeons, for surgical progress, building skills and saving lives. Thank you.